Hello, everybody. Welcome to the session on how to use imaging to deliver the clinical benefits of prostate cancer. My name is Anwar Padani, and my colleague is...
I'm Roberto Alonzi.
We're both at the Mount Vernon Cancer Centre. Today, we're going to talk to you about prostate cancer, but specifically, we'll be talking about the early diagnosis of prostate cancer and how to use modern imaging for high-risk locally advanced disease. So regarding prostate cancer, we know that we now use MRI for diagnosing prostate cancer because we know that if you have a general outpatient population where 3 in 10 men have clinically significant disease, if you were to do systematic biopsies in all patients, everybody would need a biopsy, and you would miss 111 men with clinically significant cancers if you use systematic biopsy. And you would need to do a biopsy in all 700 men who didn't have a cancer. So you would expose these 700 men to the disbenefits of biopsies, and yet you would never diagnose a clinically significant cancer in them. On the other hand, if you were to use an MRI approach, you would miss fewer cancers, 84, but only 28 men would need a biopsy to confirm the absence of clinically significant cancers. So you can see that MRI is much more likely to make a correct diagnosis using fewer biopsies in a mixed outpatient population. Now, we tend to use the PI-RADS system on a multi-parametric MRI, and the greater is our suspicion, the greater is the probability of clinically significant cancer being found. Now, if you look at men with positive MRI scans, you can see that if you count up all the numbers, 46% of men with a positive MRI will not, in fact, have a clinically significant cancer. However, on the negative side, you can see that 94% of men who we say don't have a clinically significant cancer will not have a clinically significant cancer. So you can see how we're better able to rule out disease than to rule in disease. And I'm going to ask Roberto to talk to us next about what are the harms and the benefits of a biopsy that is prompted by an MRI approach. Roberto?
Like Anwar has said, in prostate cancer, we need the biopsy not only to prove that the patient has got a prostate cancer, but also we need more information about how aggressive it is. And in prostate cancer, many cancers are never going to cause any ill health whatsoever. So it's important to do our best to avoid biopsying patients where it is unlikely that we're ever going to find a disease that's going to cause them harm. Because biopsies themselves are invasive procedures, they're painful, they can cause bleeding, and 1 or 2% of patients will require antibiotics for sepsis. But it's not just the unnecessary biopsy, it's the anxiety that comes with a cancer diagnosis. And many men will find that a diagnosis of cancer, even if it comes with an explanation that this disease is unlikely to ever cause them harm, causes anxiety amongst them and their family, and may even prompt patients into undergoing even more investigations and radical treatments for a disease that may never have caused them any harm whatsoever. So we need to develop strategies where we can bring in as much information as possible to avoid biopsying men that are highly unlikely to have significant cancers, and only biopsy men that may well have a disease that could affect their life.
Thank you very much, Roberto. So let's take an example of a man with a raised PSA and a negative DRE. So Roberto, this is a 55-year-old man with a normal DRE, no family history, a slightly elevated PSA. His PSA density is well below 0.1, and this scan has been called a negative scan, although the arrows do show possible abnormalities, but these are not definitive. So this is a typical patient with a negative cancer with a couple of equivocal lesions. So the question I wanted to ask you, Roberto, is what would be your advice to a man like this who came along to an MRI but has a negative scan?
In this sort of patient, I wouldn't rush in for a biopsy because the MRI scan has not shown any suspicious features, and it would be likely that a biopsy would show either no cancer or a clinically insignificant cancer. So this man can be safely followed up with PSA surveillance and possibly further MRI scans if required in the future.
Okay. So if we were to do a systematic biopsy in a patient like this, where there's no specific target, you would find that 3/4 of men would have a negative histology. And you would find, in other words, 3 out of 4 men would have an unnecessary biopsy with the attendant side effects that Roberto just talked about without a cancer being diagnosed. You would find 18 men with clinically insignificant cancers. So these patients would be exposed to long-term surveillance costs, but you would in fact detect 8 men who would receive appropriate therapy. Now, another way of looking at this data is to say that you would need to biopsy 12 to 13 men with a negative MRI to detect 1 cancer that is clinically significant. Roberto, is that a good trade-off?
Well, I think if you were to do this as a one-off investigation, then obviously some patients would find that trade-off was acceptable. But of course, you are not going to ignore these men completely in the future. They would be kept on PSA and imaging surveillance. So I think that in the case that you described, biopsying in that situation would result in unacceptable over-biopsying and over-diagnosis of insignificant cancers.
We also have to be aware that of those 8 men with clinically significant cancers with a grade group 2 and above, there'll be 3 men with grade group 3 and above. And do you think, Roberto, that we could do something about spotting these men with slightly higher grade? Are there any clinical factors that you would think about that you might want to consider apart from the MRI result?
Well, clearly, as in all oncological situations, you have to take all the clinical factors into consideration. You're talking about age, their ethnicity, family history, PSA dynamics, the PSA density. And you can put all of these things together in conjunction with the MRI scan and come to a decision.
And Roberto, as he was saying, if we have a PI-RADS 1 or 2, as in this particular patient, if the PSA density is 0.2 and above, you can see there's greater than a 10% chance of there being clinically significant cancer. So Roberto, is that a threshold that you use?
Certainly, it's a threshold that is part of our calculation when we decide whether to biopsy.
In fact, that's exactly what the EAU guidelines say. Roberto, do you want to say a few things about the EAU guidelines in patients with biopsy naive and patients with prior negative biopsies?
Well, yes, of course, the EAU guidelines do say that when a multiparametric MRI scan is negative and the clinical suspicion of cancer is low, then we should omit the biopsy. Of course, this is a shared decision with the patient.
And that's exactly what we discussed earlier. Okay, let's take somebody who is at a higher risk this time, Roberto. This man has a PSA greater than 10, so you can see he's just about 10, 69, Asian descent, asymptomatic, routine checkup, had an abnormal DRE, and he has 2 PI-RADS 5 lesions, and the MRI seems to suggest that he's got extracapsular disease and seminal vesicle involvement. So you can see that on the left-hand side, we've got a tumor here anteriorly going into the retroprostatic fat. We have disease here at the back going into the seminal vesicles, and we have a lesion here in the left internal iliac region, which you can see on the diffusion scans, that looks suspicious. Roberto, for this man, what type of biopsy do you think he needs? Do you think he needs a standard systematic core? Would you advise targeted cores alone? Would you suggest he has both systematic and targeted, or just loads of biopsies in both areas? Or would you say, you know what, this guy's got cancer, I'm going to treat him anyway? What would be your thought process about the type of biopsy?
This is obviously a very different situation from the previous case that we discussed, because there is no doubt that this man has got cancer. I would say that we will always want to have a biopsy, even though we know that the man has got cancer, because the tumour grade in terms of the Gleason score does have a significant impact into our decision about what treatment to give and how aggressive we need to be. And also, some of the modern systemic cancer therapies require some genetic analysis, for example, BRCA1 and 2 testing to see whether people are suitable for certain treatments like PARP inhibitors. So a biopsy will always be required. Now, of course, the important thing is to get the diagnosis. So we would want to have targeted cause of the actual tumour. But of course, we want to maximize our chances of making the diagnosis. So in this situation, I think we should choose systematic and targeted biopsies.
Yes, and in fact, that's exactly what the latest EAU guidelines say, is that when an MRI is positive, combine targeted plus systematic cause. So what do you think are the trade-offs between doing targeted biopsies alone in 2 areas versus targeted and systematic biopsies? Well, if you were to do a targeted biopsy alone in 100 men with a positive MRI, you would detect 39 cancers. This increases to 44 if you also undertake systematic biopsies. In other words, 5 to 6% more patients will be diagnosed if you do the targeted plus the systematic approach. On the other hand, if you did a targeted biopsy alone, you would detect 16 indolent cancers. And if you did a targeted plus systematic, you would detect 4 more indolent cancers. And this is the new balance that needs to be struck. In other words, for every additional man that you detect with clinically significant cancer, you detect 1 man with clinically insignificant cancers in a man who has a positive MRI. So Roberta, how do you balance that in your practice when you're thinking about the biopsy strategy?
Well, of course, in men that have come to have an MRI that appears to be suspicious, you certainly can't ignore those patients. So they're going to need to have a biopsy. So we have to accept that we are going to be diagnosing some men with clinically insignificant cancers. So we prepare these patients for that possibility, and they go into the whole process understanding that this may be the case, and they may be told that their cancer does not require any treatment, and we can keep them on safe surveillance.
And I guess missing a deadly cancer is more important than overdiagnosing a clinically insignificant cancer?
Yes, that's what most most groups would feel that we don't want to risk missing clinically significant cancer.
So in fact, this guy had targeted biopsies to both of those areas without systematic cause. And you can see he was diagnosed with a 4+5 cancer in both areas. Now, we will come back to this guy later in staging. But Roberto, before we come back to this man, let's take another man with a slightly lower PSA, but a DRE that is positive. So this man, you can see, has a normal PSA, but his DRE is positive, and on imaging, that clearly is a cancer. And you can see an in-wall biopsy of that lesion has now shown a Gleason 9 cancer. So Roberta, how would you go about staging this man in your routine practice?
So in terms of staging, this man has got a high risk cancer on the basis of his Gleason score, so he needs systemic staging of the whole body. And so at the bare minimum, he would require a bone scan, but I think we're going to talk about the potential issues with bone scans, and he may need more advanced imaging in addition. Okay.
So here are his bone scans and his CT scans, and you can see that the bone scan reports two abnormalities, one in the left seventh rib and another lesion in the right acetabular roof. And you can see that he has no concordant abnormality in either area on the CT scan. So does he have bone metastasis? Is this only two deposits? And how does this information help you go forward with having to think about what should be the next step with him?
Well, this is a difficult situation because he has a high-risk prostate cancer. The treatment, if it was a high-risk localized prostate cancer, would be an aggressive multimodality treatment. And you wouldn't want to put a patient through that if they already had metastatic disease. So in this situation, we need more information about those potential metastases so that we are as certain as we can be as whether they are metastases or not.
So you would be saying, let's get a next generation imaging technology, correct?
Yes.
And so here is the recent ProPSA study that in fact showed that the accuracy of PSMA is greater than that of bone scans, and you can see that down here. And that there was a greater management impact of the use of PSMA compared to conventional findings. And that's what he underwent. So you can see that his lesion is hot, his primary tumor is hot, but you can see there's a lesion here in the right pubic bone that's hot on the PSMA, and is abnormal on the MRI. You can see this lymph node in the left internal iliac region is also avid on the PSMA. This right iliac bone lesion, which was negative on the CT, is hot on the PSMA and is positive on the whole body MRI. And if you look at the rib, you see the same thing. So the rib is hot on the PSMA, is abnormal on the whole body MRI, but we also notice that he has polymetastatic disease. So you can see on bone scans, we had 2 to 3 lesions. The CT scan showed no lesions. The whole body MRI showed 10 lesions. The PSMA showed 10 lesions. So Roberta, now you know the truth. Do you think that the imaging has muddied the water or has clarified the situation?
Well, the PSMA PET scan has clarified the situation, and this man is now going to avoid radical treatment to his prostate that would have caused significant toxicity without any survival advantage.
So what you're saying is that you would continue to take the active, you would not take the active approach now.
We would certainly take a active treatment approach and give the patient systemic therapy using one of our systemic agents, such as chemotherapy or the modern androgen-based treatments, but you wouldn't treat the prostate radically when there are multiple metastases present.
Yes. This is despite the fact that you know that there is a survival advantage when there is oligometastatic disease on conventional imaging.
In terms of if there's just a few metastases present on conventional imaging, then we know that there is an advantage from prostate radiotherapy. Of course, in that trial, advanced imaging was not performed, so we don't know how many of those patients had more advanced disease when they were treated with radical prostate radiotherapy. So I think the jury is out in that one, but I think in general, most oncologists would not put somebody through a nasty, aggressive treatment to their prostate when it is unlikely to have a major effect in the presence of such high volume metastatic disease.
So Roberto, how do you then respond to the ESMO guidelines, which were published in 2000, which suggested that you should ignore the next generation imaging when trying to decide whether to give somebody pelvic radiotherapy?
Well, I think it's quite hard to ignore next generation imaging when it's given you a clear steer that this man has got a high volume of metastatic disease. And in terms of the clinical trial evidence, in the study that showed a benefit for prostate radiotherapy in the presence of metastatic disease, only those patients with low volume disease benefited, albeit without next generation imaging. So in many ways, you're using an argument of uncertainty to suggest to these patients that they should have a potentially quite toxic treatment without any proven benefit of a gain.
I mean, it's an interesting conversation that shows the issue of stage migration that occurs when you add next generation imaging, and so this is exactly what we were talking about earlier. So Roberto, I want to go back to that original patient with high risk prostate cancer, that Asian guy. Now that Asian guy, remember, he had a microscopic metastatic deposit in the left internal iliac region, which we could see on the MRI. Now he had a PSMA PET-CT as well. And lo and behold, you can see that the primary lesion is hot on the PSMA. The interesting thing is the disease in the seminal vesicles was PSMA negative. And this lymph node in the left internal iliac region is in fact negative. Right? So Roberto, the issue now is, what are you going to do about a negative MRI, a negative PET scan in somebody who is high risk but is positive on the MRI scan? Can you trust a negative PSMA PET scan in a lymph node?
Okay, so I think for that particular case, you have already diagnosed this patient as having a high-risk prostate cancer. So they are going to receive an aggressive multimodality therapy anyhow, using androgen deprivation therapy and external radiotherapy. Even in a negative, even if that is imaging negative, and we accept that it's imaging negative, we would routinely offer elective lymph node radiotherapy to this patient anyhow. So I think the decision would be whether you boost that as a positive lymph node. And the other decision that you'd have to make is that if that lymph node was positive, you would almost certainly give this patient chemotherapy prior to radiotherapy. So I think it would require a careful MDT discussion as to whether we really feel that this man has got lymph node positive or negative disease. And we would really need a good steer from the radiology team as to what we felt was right in that case.
Yes. And in fact, if you look at the surgical data, you can see that the sensitivity of PSMA PET-CT for small lymph nodes that were surgically resected is only 50%. And so the important thing is, how important are these microscopic lymph nodes that are regularly missed on a PSMA PET-CT scan in terms of your radiation planning? So, Roberto, I don't know if you remember this data that was published recently, showing that if you treated the prostate and the pelvic side walls, you had a better biochemical free survival than if you treated the prostate alone. Ditto for disease-free survival and distant metastasis-free survival. Do you have any comments? Does that corroborate your approach or not?
Well, the role of elective nodal irradiation in a imaging node negative patient has been a very controversial area in prostate oncology for many years. And there have been several studies that have shown benefit, and there have been several studies that have shown no benefit. And currently in the UK, there is a very large randomized clinical trial that is currently recruiting that will be larger than any other trial in this situation that will hopefully give us an absolutely definitive answer. And I think that the issue is that you have to take everything in context. If the tumor characteristics suggest to you that you are likely to have nodal metastases, even if the imaging doesn't say absolutely that they're definitely there, you would still be more inclined to want to treat the lymph nodes electively. And I think you'll find that within the oncology community, there is actually a variation in this area.
Okay. So, Roberta, I wonder if you would finally give me your thoughts about what are the barriers to the adoption of next generation imaging for your patients, be it locally advanced, high-risk localized cancers or advanced prostate cancers. I wonder if you'd be able to summarize what you see are the barriers to the adoption of these technologies.
Okay, so I think the obvious one is availability and cost. It is about adding extra investigations into what is already a very tight timeline that we are required to work within in terms of getting patients diagnosed and treated. It is also, like we've already discussed, that we are not exactly certain how the stage migration that it would cause would mean that are we now going to be slightly over treating patients because these patients were all there anyhow and they did very well with less aggressive treatment, but now we know that they've got disease elsewhere. We're going to be increasing the aggressiveness of their treatment without definitive evidence to do so. And I guess also there is the general aspect that people get a bit stuck in their ways, and they know that they've learned over the years to understand multiparametric MRI scans, but they don't quite understand PSMA PET scans and whole body MRI scans and things like that. And it's like everything else, it takes a while for that to permeate into routine clinical practice.
Okay, Yeah, I mean, exactly right. And, we see these barriers being discussed in MDTs, and I'm sure in your MDTs you will also see such discussion. So these are my take-home points regarding prostate cancer diagnosis, and then I'll ask Roberto to give you his take-home points about next-generation imaging for advancing disease. For diagnosis, I think you have to be careful about who you use MRI from, because there are patients who don't need a comprehensive approach, particularly those patients with a very raised PSA and an obvious cancer. They may not need the comprehensive approach. Clearly, you need to pick your man well based on clinical factors, PSA and DRE. Remember that, as Roberto said, you may not find all clinically significant cancers immediately, but you need to have appropriate and robust safety nets for negative cases who don't have an MRI. And you need to use the MRI as a roadmap to decide where to biopsy. So Roberto, your final thoughts on the use of next generation imaging for the more advanced disease, the high risk localized disease and the metastatic disease.
Well, clearly, I think that the most important part of the next generation imaging in the more advanced cases is that we will have a much better idea of the exact nature of people's cancers and how they're responding to treatments. Because if you can't see half of the disease to start with, then we are blinded to really how our treatments are working. Now, it may well be that we don't quite understand how the next generation imaging is telling us about how our treatments are working, and we're seeing mixed responses and things like that we don't quite understand yet. But this will come and will give us a much more discerning tool to tailor and manipulate our treatments on an individualized level.
Yeah. So would you say that we're at the point where we would use next generation imaging as the first modality, or would you say it would still be the other way around after a bone scan and a CT scan?
Well, in terms of, I think you have to choose your patients correctly, but for the more advanced cases, if resource was not an option, then I would probably go straight to a next generation imaging and just leave out the bone scan.
Okay, all right. But the interesting thing is the ASCO guidelines are still the other way around, which is also quite interesting. So the community is shifting, but shifting slowly, as you said, and it depends on your own availability to these new technologies. Well, Roberto, that's all the time we've got today. Thank you very much for entering into this discussion, which I think was very interesting. Thank you, Roberto, for your input.